That's a very, very complex question that has been the topic of frequent debate. Again, you have the functionalist, I would say, who doesn't look, literally doesn't look at the plaque burden and just base their judgment on the threshold of 0.8 or 4.75. And there are people who said, yes, but what about the plaque burden in a lesion of 0.85? And then if you check the literature, if you talk to people like William Wentz, Gary Mintz, and many others, there is this concept that you may have an important plaque burden, but that plaque burden has no prognostic value if it is associated with an FFR which is good. How to explain that? Nobody explained that, but certainly Gary Mintz and others said that the fact that you have a high FFR suggests that in case of ruptures, the coronary system will be able to digest the embolization process or the thrombus superimposed to the plaque ruptures. So the function in a hierarchical view is somewhat above the anatomy. Now, you can argue that with some tissue characterization, you could have an extra unpredictable, an extra information about the unpredictable character of that lesion. But still, if the flow is able to digest the plaque ruptures and the superimposed thrombus, you will not have a major clinical event. And we have sometimes captures that. I mean, we have published this famous case where we saw a plaque rupture during catheterization with OCT, not with IVUS, but it was very precise, very crisped with OCT. And we followed the individual for 52 minutes, it has been published, and in 52 minutes, the cavity of the plaque ruptures was filled, probably with platelet, but not superimposed thrombus, because there was plenty of flow there, and there was no FFR flow-limiting lesion. I think that's very important, how the flow and the flow of the coronary artery can digest the superimposed thrombus of the plaque ruptures. Difficult to prove.